Hello friends, welcome to the Emergency Medicine channel. Myself Dr. Ashik Envy, doing post-graduation in Emergency Medicine. In this video, we are going to discuss about hyperkalemia. As you know, the normal serum potassium value is 3.5 to 5 milliequivalents per liter. But the hyperkalemia is defined as a serum potassium value more than 5.5 milliequivalents per liter. Now let's see what are the causes of hyperkalemia. Okay, causes. The first cause is pseudo hyperkalemia. Okay, pseudo hyperkalemia. It is seen in hemolysis, or by using a tonic use. Also seen in leukocytosis or thrombocytosis. Okay, these are the conditions causing pseudo hyperkalemia. The second cause is extracellular shift of potassium. Okay, extracellular shift. As you know, potassium is the major intracellular cation, but in certain drugs or certain conditions there will be extracellular shift of this potassium ion which lead to hyperkalemia. Let's see what are the conditions causing extracellular shift. First one is acidosis. Okay, already discussed in hypokalemia section, that is acidosis causes increase in serum potassium value and alkalosis causing decrease in serum potassium value. Okay, and the second one is beta blockade or a deficiency in insulin. Okay, insulin deficiency. And digitalis intoxication. And finally hyperkalemic periodic paralysis. Okay, these much conditions causing extracellular shift of potassium ion. And the third condition is potassium load. Okay, potassium load. Okay, potassium load is either due to increased supplement of potassium through dietary intake. Okay, increased supply of potassium, or may be seen in patients who are taking IV potassium for correcting hypokalemia. Okay, or patients using potassium sparing drugs. Okay, or also seen in hemolysis. And the final condition causing hyperkalemia is decreased excretion of potassium. Okay, excretion of potassium. It is seen in renal failure. Okay, renal failure. Also in aldosterone deficiency. Aldosterone is a hormone causing excretion of H plus and K plus ion. But in the deficiency of aldosterone, there will be decreased excretion of potassium ion. Okay, aldosterone deficiency. Now let's see what are the clinical features of hyperkalemia. Okay, the major clinical feature of hyperkalemia is nothing but cardiac dysarrhythmias. Okay, it can cause either AF, that is atrial fibrillation, or asystole, or complete heart block. Okay, and it is also causing death due to this dysarrhythmias. The death may be due to either ventricular fibrillation or due to a diastolic arrest. Okay, heart will stop in the diastole. Okay, these are the major clinical features of hyperkalemia. Now let's see how to investigate a case of hyperkalemia. What are the major investigations you should not miss in patient presenting with hyperkalemia? The first one is nothing but ECG. Okay, because the most common complication associated with hyperkalemia is dysarrhythmia. You have to go for a immediate ECG, and you have to you can interpret the ECG like the following features. Okay, now if the serum potassium concentration is somewhere between 6.5 to 7.5, you will get some ECG features like prolonged PR interval. Okay, prolonged PR interval, or tall peaked T wave, or short QT interval. Okay, At a concentration of 6.5 to 7.5, these much features you can observe in ECG. But if the concentration is between 7.5 to 8, there will be flattening of P wave, or QRS complex widening. Okay, and if the concentration is much more higher, that is between 10 to 12, you will get a sinusoidal pattern, that is a sine wave pattern of QRS complex. Okay, so by using this method, we will get a rough idea of serum potassium concentration by looking the ECG features. Okay, that is the significance of the ECG. Okay, now after taking ECG, you can also take a spot urine potassium value. Okay, and you can interpret it like, if it is more than 20 milliequivalents per liter, that is the potassium is adequately excreting through the renal system. So the cause for hyperkalemia is not associated with the renal system. So the cause is extrarenal. Okay, the cause for hyperkalemia is extrarenal. And if it is less than 10 milliequivalents per liter, the cause is renal only, because there is a decreased excretion of potassium ion. The cause can be renal failure, or it can be due to drugs like ACE inhibitor or ARBs, okay, angiotensin receptor blockades. These are the major investigation have to be done in patient with the hyperkalemia. Now moving on to the treatment part. Okay, the treatment part consisting of 3 important mechanisms. First one is membrane stabilization. It is the first treatment should be aimed to stabilize the membrane, especially in cardiac system. Okay, membrane stabilization. The second one is intracellular shift of potassium. Okay, the second treatment should be aimed to shift the potassium from extracellular compartment to intracellular compartment. And the third part of the treatment should be aimed to excretion of potassium. Okay, so the first we have to be concentrate on membrane stabilization, then move for intracellular shift of potassium ion, and then excretion of potassium. Okay, and before starting the management, it is better to take an ABG. Okay, and if the ABG shows a pH of normal or alkaline value, okay, normal or alkaline pH, then there is less role for drugs which acts to promote intracellular shift. Okay, if the ABG shows a normal or alkaline pH, there is less role for drugs acting by the mechanism to promote intracellular shift. So we have to concentrate more on excretion of potassium. Okay, drugs which will cause excretion of potassium. Okay, that is the significance of ABG. Now we have to go for the drugs part. Okay, which all drugs are given in case of hyperkalemia. The first drug is always calcium gluconate or calcium chloride. Okay, both are 10% in concentration. Okay, and given via IV route, and the mechanism of action of both are same. They are used for membrane stabilization. Okay, membrane stabilization, that should be the first step in order to prevent the dysarrhythmia. And the second drug is beta agonist like salbutamol. Okay, here the mechanism is intracellular shift of potassium. The third drug is insulin. Okay, it is given like 10 units of regular insulin in 100 ml of D25. Okay, Here also the mechanism of action is shift of intracellular shift of potassium ion. Okay, and you can also give sodium bicarbonate. Okay, here also the mechanism is same, that is shift of potassium ion, but the regular or routine use of sodium bicarbonate is not promoted nowadays. Okay, after the 2015 update, the regular use of sodium bicarbonate for treating hyperkalemia is not recommended unless there is acidosis. Okay, and the fifth drug is furosemide. Furosemide is used for the excretion of potassium. Excretion of potassium. Okay, and you can also go for hemodialysis if the serum value is very much higher and patient is at risk of cardiac dysarrhythmias, then you can go for hemodialysis, and here also the mechanism is excretion only, excretion of potassium. Okay, so these are the drugs commonly used to treat the hyperkalemia. Now there are certain general principles, okay, have to be followed while treating hyperkalemia. General principles. Okay, and it include, first one is, if we have detected hyperkalemia in a patient, we have to be immediately stop further potassium administration. Okay, or the drugs which will increase the serum potassium value like ACE inhibitors, ARBs, NSAIDs, or potassium sparing diuretics, that those drugs should be stopped. And the second one is fluid administration. Okay, there should be a rapid fluid administration because the fluid administration will increase the excretion of potassium through the urine, via urine. Okay, and third one, there will be continuous ECG monitoring. Okay, so these are the certain general principles have to be followed during hyperkalemia correction. And nowadays there are two new drugs, oral drugs, okay, for potassium binding. Okay, for potassium binding, and those drugs are, first one is patiromer, and the second one is sodium zirconium cyclosilate. Okay, these are the two newer oral drugs for potassium binding, with the potassium binding property. Okay, that's all about the hyperkalemia. Hope you enjoyed the session, and kindly to subscribe my channel if you are interested in emergency medicine related videos. Okay, thank you for watching.